Welcome, guys. It's Dr. Sausha here with you guys today, and you are tuning in to Clinical Unfiltered. So give me your hearts, your minds, your teeth, and let's get unfiltered with Dr. Parikh. She's back to talk to us about. I actually think this is a great collaboration talk because we are going to be talking about the implant abutment connection, which is where the worlds of perio and pros begin to blend and merge together in the implant ecosystem. Um, and I am very passionate about it, and I know Dr. Parikh is very passionate about it. And if you are listening and you are not passionate about the implant abutment connection, I will haunt you like The Ring, that freaking movie. Yes, I will. A little demon will crawl out of the implant and come and choke you at night if you do not care about this. That's how passionate I am about it. I don't I when I place implants, I always ask the patients when they go off to get restored by the restorative doctor that they follow up with me afterwards. So it's a conversation. It's like, hey, it's the doctors that I refer and work with love it that I bring the patient back to me to check. I take a PA, I check the contacts, I check the bite. Even though I didn't do the restoration, I just also want to check that implant. Really, really, we just want to check the implant and the abutment, how they're kind of merged together. um, and one final check. And a lot of the restorative doctors that I work with, these are doctors who do not typically, they don't know a lot about implants. That's why they're having me help, with the implant process. And so it's critical that I send these patients off with a good implant abutment connection. I'm done preaching a little bit about how much I care about it because I literally waste a whole appointment on these with these patients. They don't charge it. I don't charge them anything for that checkup.
Of course, you can't. Yeah.
Why are you passionate about the implant abutment connection?
I'll tell you the most immediate reason why I'm passionate about it is in my practice earlier this week, I had a patient come in and she reported pain on the lower left side. She had a lower all on X. It was 6 implants. And we accessed them and went to remove it, and the implant came out. And she told me once I retrieved the records, I saw that they had had repeated issues with the abutment that was connecting the prosthesis to that implant. The abutment had broken once, it had stripped once, it was never fully torqued all of the way down. And here this person is in my chair, and I was doing surgery. I was explanting an implant.
Not
So
a
that
hard
on
one,
the
apparently. Not a hard surgery, apparently.
I mean,
It's,
Sasha knows this because I told him this, but like if someone's getting surgery by me, it's like class 3 mobile, flapping in the wind, get it out. So that's why, like, most immediate reason why I'm passionate about it. But outside of that, I mean, I have a whole lecture series on the dental implant abutment connection, and it all started a couple years ago when I was developing content to lecture with, and I came to some of our industry partners and I said, why don't we talk about the abutment? Like, why is no one talking about the abutment? Because here's the problem is in the abutment world, there are so many options. And if you don't know what you're getting or what you're doing, then you're going to enter the complications field. So
I'm going to preface this with the majority of the options are bad.
yeah.
I'm going to
Bad
go with
options.
that.
Yeah,
Yeah,
exactly.
I see it a lot.
So,
But,
I
yeah.
mean, we've talked about like an earlier podcast we did, we talked about like implant complications. And so, as I was developing the course for implant complications, this is like the natural thing before it to avoid those complications
Right.
from happening. And one of the things I say always is the dental implant abutment connection is the most critical part of success for the entire dental implant complex. It is also the weakest and highest point of failure. So you have two things that are true at the same time. And yeah, that's why I am passionate about it, outside of being a nerd about all of the things.
Well, no, even as a straight pure clinician, caring about like these things actually working, the implant, like the truth of the matter is cement's not the problem. It probably hasn't been the problem. it's been the abutment connection. That's the real problem. That's
An
always been,
abutment
yeah.
an abutment selection.
Hmm.
Like for I feel like that's a big area too, is it they go hand in hand, right?
Gotcha.
Is like
Yeah,
the
yeah, yeah.
connection, but like also
Right. My head's like, you're
selecting the
thinking the
abutment.
forces that get applied to the
Yes.
abutment. My head's thinking that actually how it inserts into the implant
Insert
and
to
the
the implant,
biologic
exactly.
problems that then come from
Yes.
that.
Yes.
Um,
I mean, they both go hand in hand, right? You can't have one without the other. Um, but both can be problematic if not done correctly.
so I mean, I feel like let's draw back to the types of connections. And it has a little bit to do with like obviously the implant, how the two come together, whether the implant has on its internal surface, if it's internal hex, got a taper to it, uh, uh, if it's conical connection, internal hex or external hex. I really don't think we like external hex only comes to play when you're talking really these days about multi-unit abutments. Because otherwise, we're not really talking about external hex. So it's either your implant's probably either internal hex or conical connection, and most implants on the market are internal hex. Most. I don't know a percentage number, but I'm gonna throw out like 95%.
But not all hexes are equal. They're not all hexagons and they're not all the same.
That is true too. That is true. Although I do think the most common one that I've found is that I think it's like BioHorizon 3.5, Zimmer 3.5, MIS 3. It's that standard hex, that 6 hex. That's the most common one that I've seen most like copycats copy. And maybe it's just an easier thing to manufacture, but most like if you're having a BioHorizons internal hex, that 3.5, I don't know exactly what color it is, but that one I've seen repeated a lot.
The reason I bring that up is because again, what you said at its very like base level, right? The abutment is dependent on what the internal connection or the connection of the implant is. And already at that very base level is so many areas that I see people get caught in or there are failures occur because when you don't identify properly what kind of hex it is, what type of hex, and you restore not uniformly, you're already not setting that implant and that abutment up for success. So, what I mean by that is, like you said, BioHorizons, MIS, Implant Direct, the Zimmer, those have similar hexagonal connections, but they are not interchangeable hexagonal connections. And they are also not the same as certain third party hexagons that are available. So if you used a Zimmer on a BioHorizons, you're not going to get the same result with using the same like OEM parts or original parts for that manufacturer.
There is a different like the lab and the companies that sell you the parts, they're gonna tell you they're within a tolerance range, or they might not say it. They might be like, yeah, 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 same, but different. They won't say that, but they I mean, they've done studies to look at the exact same parts, like the BioHorizons, the MI, like they've looked at their internal hexes. They're within a range of similarity. They're never like an exact copycat because they don't allow each other to do that. They won't give each other the exact, and they're not manufactured in the same place.
Exactly. And why would they? Like I always tell, whenever I see complications or I'm lecturing about it, I always say you at the like take a way step back. Take your like clinical hat off, your white coat off. This is a capitalistic market. Like why would we share when we can just make our own implant company? Like
BioHorizons is not going to want someone buying their scan bodies to place on a Zimmer. They would have made some. They can't. So like there are some differences there. Now, granted, how much clinical impact it is, that's up for debate.
that's what I was gonna be. That's the next thing I was gonna say is like the tolerance thing is very true. And like we have tolerances all around dentistry, right? When we do a simple crown, you have a cement gap. A cement gap is what? A tolerance, right? It's 100 microns or 80 microns that you are saying, hey, I'm really close, but give me a little wiggle room and I'll fill it with cement, right? We do the same thing in implant dentistry and dental implant abutments. The thing is, for 90% of the population, it might be fine. Really, it might be fine. But in a distal molar, second molar, heavy clencher and grinder, not wearing a guard, improper occlusal support, yeah, it might not be okay, you know? And so it's very situational. And I think that again, the hard part sometimes, and why it's so cool that I think we have like surgery and pros talking about it, is because if surgery is not looking at the whole case, right? Like the occlusion, the person, the bite, they might select an implant that has a connection that is not favorable for the restorative doctor. As the restorative doctor, like, I don't have a choice. You placed an implant, it's integrated, I've got to restore it, right? But also vice versa, you might have done everything perfectly. And then the restorative doctor comes in and is like, hey, I want $100 off my lab bill. I'm going to use
Yeah, yeah, yeah.
these
But you do
parts,
have,
right?
but then you do have
Like,
selection of the abutment type at that point
you
too,
do.
which I've seen
Yeah,
people pick the wrong abutment type for what I was like hoping for. I was like, man, I was really hoping for this kind of abutment type in this
totally.
specific scenario. Otherwise, and this is the thing. I mean, it goes with anything in anything you do, but include especially implant dentistry. It's like people want like I do X, I do A because of B, and it's like a linear decision tree, and it's not like that. Especially when you have like it's like okay, you could place this implant with this kind of abutment type and this type of connection in this part of the mouth, but you probably can't do it in this other part of the mouth in this type of patient. That's not linear. That's got so many layers of thought and gray. It's not black and white. It's very gray. So you have to be ready to swim in that. You absolutely have to be able to ready to swim in that and understand that.
And get your patient to understand it too, right? Like that's the other part of this capitalistic society of implants. I have a case in my office right now, referred to me for fractured abutment and strip screw. Literally, abutment was cut, sheared in half, and the screw was stripped. We retrieve everything. It's an old Astra implant, and it's in site number 3, and it's deep. Like the tissue column there's a lot. And so I told the patient, I was like, hey, I don't see a reality in which we go straight to final here because this tissue has collapsed totally in. I need to get it out of the way or contour it so I can get explain like emergence profile and all of that. And then we need to do a custom abutment because you've got the implant up here and your bite's down here. I've got a lot of space I have to traverse. And we're going to do a custom abutment. We're going to make this implant crown. And the patient was incredibly understanding, but also I have the benefit of being a prosthodontist. And I understand that. I feel for some of our general dentist colleagues because they are battling a lot of battles, right? They're battling insurance coverage, they're battling patient expectations. And again, when we take our big bird's eye view, this is a capitalistic society. There's so much marketing around getting implants in a day or getting them at $2,000 all in or whatever it is. So
And I mean I'm gonna call it what it is. They're using a small tie base with a zirconia. That's what it is all the
exactly,
time. By the way,
exactly.
if you're not aware that that's what you're getting, and you are like you get a lot of implant crowns, that's probably what you're getting from your lab
Yep.
is a small tie base.
100%.
Their stock OEM, not OEM, their whatever company desk, whatever company they
Yep.
could bulk buy the tie base
Yep.
from. With a giant crown on top of that tie base. The
Yeah. Totally.
like the understanding of where to put what type of but the ultimate nature is like you really can't have multiple implants in the mouths, but the abutments where you can be a little bit more flexible, I think, with because as surgeons or doctors, you can't have 5 different implant systems in your closet. That just doesn't make economic sense. But it makes more sense to be in controlling of your abutment based off the type of location and certain case like aesthetic cases you can handle differently. Maybe you want an angled screw access channel. That type of abutment is different than a custom abutment that you might have on a number 3. But diameter of implant, the way I explain to my patients is I always tell them because I do the guided process. I explain that to them and I make it seem like it's dumb that no one else does it. Like part of the education process. I try to be frank with the patients and I tell them part of this lets me see what like the implants come in so many different shapes and sizes and they're not all right for this specific tooth that you have here and I'm going to in the software try different ones out and find the one that's right for you. It's a whole personalized care concept. And so I have that conversation with my patients too. And then it's a part of the conversation when I send them off to the general dentist. Now, granted, most of the times I have a working relationship with them, so I can send it off and have that communication where it's like, I'm going to check just to make sure the doctor likes me to check. Most of these doctors like me to check. And I have a very politically correct conversation too, if it's not correct. You know, I try to help out, yeah, both the patient and the doctor who restored. I try to take care of both of them. Um, the other type, besides internal hex, is conical connection, which is my preference in connection. Couple things, reason. I mean, they've done a study. They've done studies on these different types of connections, attached abutments to them, and one of the key things that I found is that microleakage concept. Um, and between internal hex and conical connection, I mean, it's like cone shaped on the inside. It's got like a deep V, so the abutment presses against it, and there's like a counter push of the implant against the abutment. And honestly, sometimes even without once you torque it in, sometimes you could take the prosthetic screw out on a conical connection, and it's like still stuck there. It's tight, so stuff naturally leaks less through that connection. Which is why I don't know if anyone's ever heard this, but with conical connection implants, you can sink them in the bone a little bit deeper, technically, if you need to, and not take away that bone because it'll actually keep that bone integrity because there's less inflammation because of the less amount of micro leakage that you're getting. And they've done studies where they've like swabbed the inside of the implant and before and after an abutment connection, and then the ones with internal hex have a bunch of gunk inside of it, and the ones with a conical connection are still have some. They're not completely devoid of material. That shows you even when you're torquing and sealing the abutment, stuff still can pump inside and outside of that implant. If you've ever taken off an implant abutment and smelled inside of there, it smells awful. That's just like a
Or look
garbage
at
can.
it.
It smells like a
It looks
bottom of a trash can. Yeah,
yeah,
yeah. Look
and it
at it.
looks black. Yeah, it looks like
Yeah,
there's stuff there. Yeah.
stuff. It's
Um,
brewing like like a low
yeah.
oxygen environment. You know, it's the nasty stuff. It's
Yeah.
the nasty stuff, and that
It's the
stuff gets.
really nasty
And if
stuff.
it pumps out, the more it's able to pump in and out with the
Yeah.
micro leakage, the more you're going to develop inflammation from these
Yep.
byproducts and bacteria. So the internal
100%.
hex, the dieback of 1 to 2 millimeters is almost expected in these
Hmm.
internal hex. Even with a platform switch, a little bit of dieback is
Correct.
still anticipated. And then
100%.
platform switching, of course, is another concept. If you're not familiar, the abutment is a little skinnier than the head of the implant.
Yeah.
And
Just have a
so
little switch.
internal hack. Most implants are to some extent have some of that, but not all. Not all
Yep.
implants are platform switched these days. Even new ones that come out, not all of them are guaranteed to be platform switched. But even if it is internal hex, you're still gonna get some micro leakage. They have some really good like. Have you seen these videos that in one of the studies that they've done where you can see the flexing of the metal?
The metal.
Um,
Yeah. Yeah. Hmm.
yeah, I forget that. I've
Yeah.
put it in presentations. I can't remember the author who
Yeah.
did it, but I love them
Yeah.
for doing it because it's a beautiful video to show how the metal actually flexes and how you can create micro openings in the when they're biting on the
Hmm.
implant. And if the bite isn't like truly straight on and it's off axis, which let's be real, there's likely some off axis forces happening on these.
Always.
Yeah,
Always.
so
Yeah.
you're gonna be flexing a little bit and getting a little gunk in and out of there.
The only thing I would say is, and again, for me, I don't place implants, so I don't generally guide preferences because I understand that there are other biological reasons why you would want a certain implant over another implant, right? Like the type of bone, the person, medications, medical history, all of that. But in my experience, especially as conical connections have become a lot more popular, you see some of the really big implant manufacturers pushing, right? Like Straumann came out with their BLC. There are this is really big push for conical connection. On the prosthetic side, it is even more imperative that things are seated correctly.
Oh God, yes. I'm
Because,
glad you brought that
yes,
up. Yeah, I
so
forgot to
with
bring.
an
Yeah,
internal connection, right, or things that are hexagons, there it's pretty obvious. Like when you put it in, it kind of
clink.
clicks
Yep,
in and
yep.
you're like, okay, I'm in all of the way. When it's not in all of the way, it's incredibly obvious to tactilely, but it's also incredibly obvious on a radiograph. Very obvious. Conical connections are generally octagons, they used to be square triangles. They used to be trilobes, like
Hmm.
triangles, and now they've moved to making them more like octa connections or octagons. And the problem with that is the indexing of the octagon is it's a lot smaller. So it's easy to feel like you're seated all of the way and then not be seated all of the way. So I really find that is one area, as I've seen more of a shift towards conical connection, where restorative dentists can get tripped up. So like always make sure if you are seating your scan body or your impression coping, take the radiograph and take it from that incredibly parallel angle, so you can make sure that it's down all of the way.
It's crazy. I actually did lose, like, I did this insane bone graft, insane immediate implant case. Implants like in the most perfect position it could possibly ever be. It was a prime taper implant, but the doctor had zero experience with conical restorations and had only experienced the internal hex of BioHorizon. And he was like chewing me out. He's like, "What? Like this doesn't even like. How do you?" I'm like, at one point, I knew I was losing the referral, so I just straight up I went to the doctor. I was like, "Look, if you can't handle it, I'll just take care of it." And then I went to call and, like, the patient was like in the midst of it. I was like, "Look, your doctor is struggling with this. I will gladly take over." Mainly because their attitude towards it. Like if they would have been like, "Hey man, can you help me out?" Been like, "Okay," but they were calling me out on. I was like, "No, dude, trust me, we did miracles here." It's tougher to restore. It is tougher to restore the conical connections, and for that reason, and you're right. And what Dr. Parikh is like referring to is at the base of the cone shaped abutment on these conical connection abutments. There is technically some indexing. There still needs to be, and it can't just be a pure cone going in. There has to be some indexing so that it's anti-rotational, and at the bottom is where it is, and because it isn't just all hex, the indexing is smaller inside, so it's got more. It's got a little bit, like the tactile sensitivity is much less in that kind of scenario.
Exactly. And
Yeah,
and also because it has that wedging effect, so it's the abutments pushing on the
yeah, you
implant,
feel
the
like you might.
implants
Yeah,
is,
yeah, you feel
yeah,
like you're getting tight.
exactly.
Yeah,
And often it can be deceiving. Like you can be like, "Oh, I'm seated, everything's perfect." And
yeah.
then you go to torque it and it spins out, or you go to take a radiograph and you're like, "Wait, that doesn't look normal." So I agree. I think they are a little more challenging to restore. I also think that there's a lot of noise in the conical connection market that restorative dentists have to be very careful about. And what I mean by that is, we know, like I tell all of my patients this, like implants are like cars. You can't use a Honda part on a Cadillac. Like that's not how it's going to work. So we need to make sure that we are staying manufacturer
Oh yeah,
specific. But
especially for
even
conical.
especially for conical, and
Especially for
but
conical.
even within the
Uh-huh. Yeah, yeah,
manufacturer,
yep.
you have different conical connections, or you have different connections. So if you're using like prime taper, you have to make sure you're using that family, like prime taper EV, like you're using that family of products. And you have to make sure your lab is also using that family of product. And this is where it can become very disjointed or very confusing. And really, like at the very base of it, as a restorative dentist, what do I care about? I care about the crown fitting. I care about the contacts and the occlusion, and I care that it's less than a 30-minute appointment or hour appointment,
Right,
right? Like I
right.
don't
You
want
don't
to be
wanna be
sitting there for
guessing, like, what
4
is it? Is it the
hours.
abutment
Yeah.
that's not fitting? Is it the contacts?
Right.
It could get annoying, yeah.
Exactly.
You want it to be
Yeah,
smooth as
absolutely.
butter.
Exactly. And so your labs are going to do all the things to make it smooth, but they might be making choices that in the end aren't the best for that restoration.
I do think, like, I've seen some of these AI, based, image recognition, apps for finding out what implant it is and using that to kind of then figure out what kind of a connection you need for it. But if you're not sure before you restore, be sure. Uh,
Yeah.
you
Or just
know?
get the sticker. Like if you can just
Yes, I
get
got
the
it.
implant
Yeah.
sticker, like then you're golden, right?
Yeah,
Then it's
let's
a
all
no-brainer.
share. Let's all share that information. I've had people withhold it. I've had dentists be like, "Nah, we don't have that anymore." I'm like, "What do you mean you don't have it anymore?" And you're like, "It's in your chart somewhere. Give it,
I
please
feel like
share."
we
They're like,
might
"The
have
patient
talked
has to
about
come
this.
in and pick this up," and I'm like, "What?"
Yeah. We might have talked about this on another podcast, but I think you might have heard me lecture about it. I give everyone medical device cards, and
Yeah,
they're for their dental implants.
we did. We
Yes,
did talk
every
about this.
patient finishes their case with me. It's their name, the date that we restored it. It's the implant information, the actual implant information. And then on top of that, I include the abutment. I'm like custom abutment restored with whatever screw, zirconia crown, angulated screw channel restored with, whatever it is. Because I know that on the flip side, if you sent me a patient and they had this card, like
Oh my
I would be
God.
stressed. I would be
That would
golden.
be
I'd be like,
so
all
great.
right,
Oh
cool.
man.
And
That that
it's
you,
it's
we did talk
it's
about
not
this.
fair. Yeah,
We
it's
did talk
not
about
fair to
this,
our patients
and
because they don't know.
I said let's make it an NFT, like a non-fungible
Yeah, oh
token.
yeah.
And so that way
Yeah.
the patient doesn't even have to carry a card. It's on their phone,
Literally.
you know,
It's on
like
their phone.
yeah, or
That's our next business idea is how do
uh,
we get it into their
implant
Apple wallet?
NFTs. Yeah, yeah, yeah. No,
Into
exactly.
their Apple wallet.
Honestly, I don't think we're too far off from tokenizing the medical info and patients choose who gets to access it. But you put your that's like that the notes go into their system and then whatever wallet, their health wallet, and then you get access to that health wallet. But the so those I mean th- those are the two connections. I mean my main philosophy on going with the conical connection. This is the thing. If the market was purely based off how easy is it to use, we would probably all be using internal hex. So the fact that there is a conical connection market and new implant systems are strong companies are coming out with new implant systems that have it means that it's got value, and that value is to the patient really, like it's the better connection.
It is. It absolutely is. And these nuances with time, we will get better with them, right? But I agree 100%. Like the data supports it, and like you said, the market's moving in that direction.
But again, the tolerances are lower, so there is a learning curve to it. Agreed. The uh, uh, the process of doing you're scanning everything.
Everything.
Gotcha. Yeah.
Gosh, the other day I had to make a open tray impression because these were old Branamark implants. Like, I mean,
I gotcha.
finding parts for them was like I was going on a scavenger hunt. And the whole time I was like, what am I doing this? I was just like so upset.
Right. It's funny. We got a new Trio scanner, and it scans a little differently. Got like the Trios 5 or whatever one just came
Mhm.
out. She has 6. I'm not sure. The scan body was being funky, and I was like, man, we had to move. And I looked at pull the drawer. I had one closed tray impression coping, and I said, nah. I
No,
still was like, nope, still not picking it up.
nope.
We'll
Yeah.
figure out the scanner
We'll figure
situation.
it out. Yeah.
The
Yeah, no, we're scanning everything.
the uh, uh, the micro leakage concept too, when it comes to implant abutment connections. I've seen theories where like the creation of the micro leakage. One thing is the bacteria leaking, also the formation of nano titanium particles or titanium particles from the micro motion that can be developed. And this has been shown, plenty of times that we can induce titanium nanoparticles by bad occlusion on implants. And I think it has to do with that. Is the micro gap? What kind of connection? How much movement? How much tolerance have you given that abutment? And that micro motion will create those shavings of nanoparticles of titanium, and they have been linked over and over again to very bad systemic problems, mainly inflammatory based. And I don't think that gets studied a lot because I think all implants, even the good ones, kind of still do a little bit of that. And that's a terrible thing to kind of pour out onto the implant market, that these phenomenal replacement options we have ultimately still induce some amount of inflammation.
Yeah, I mean, but I also think like I think nor other restorations do too, like a deep class 2 composite or a deep margin or a severely broken tooth. I think any even natural dentition, if you're not cleaning properly and you've got calculus subgingival, like that's an inflammatory reaction, right? I think in general we want to avoid it or mitigate it as much as possible. But your point about what's released, right? And the reason it's so hard to study is because the end result is what? implant failure. The implant fails, right? That's like literally this case that I just said I saw in my practice. That's exactly what happened. The abutment implant connection was unstable. She was functioning on it for many, many years. And over time, it failed, right? And it failed probably because there were some of those titanium particles that got released. Definitely because there was some micro leakage. I mean, when it was removed, the site was horrendous. Like it was super red, super angry. So yeah, I think like in general, if we're going that deep, like yes, of course, like implant dentistry is a great replacement. It's not going to be like a natural tooth, but also natural teeth have their own problems.
Yeah. No, it's a
But
good
more
counter argument to
importantly,
that
yeah,
concept. It's like still do everything you can to reduce it.
right.
Conical connection,
That
well
was gonna
fitted
what I was gonna
abutment.
say is
Yeah.
more importantly is like mitigate the risk. Like make sure it's stable, make sure it's seated, make sure it's the right abutment, the right screw, the right occlusion. It's not as simple as sending it off to your lab and saying, "Make me a tooth."
Right.
Like,
Right. No, for sure. And then the other concept too is like right now I've been mainly talking about bone level implants. And like I said, you want to try to keep as much inflammation away from the bone. So if you can put an internal hex implant, connect a good abutment to it, even a good one, at the bone level, you can induce some inflammation, expect some dieback of the bone. And that's going to be normal to a certain extent. The worse the abutment connection there, the more potential issues you're going to have. The other thing is tissue level implants, which takes that connection and brings it a little bit higher, which I don't hate that concept. I do like the idea of kind of shifting that abutment connection higher up. And they've got like, another thing in that process too, often you're not disrupting that tissue from the process of removing the abutment on and off, which has been shown to cause bone loss if you take an abutment on and off, even a healing abutment on and off a bunch of times. So they've got like the one-time abutment concepts. They have the MIS has the connect abutment, which is like a healing abutment that's got an access hole inside of it, so you don't take it through the tissue. And then of course there's just tissue level implants. They are harder in the sense of like trying to nail it as far as like where is that margin going to end up. They've got a little bit more technique sensitivity there, but I do like it's got a good thought process behind it.
I have never had any qualms with tissue level implants as an implant itself. And I've had patients who have had them for like decades at this point and like no issue. I have issues with tissue level implants when they are placed in the wrong situation. So, like, case in my office, it's site number 30. 30 was missing for a really long time. 31 has completely started to, cave into that spot. 29 has this huge, like, DO composite, and a Straumann TLX implant was placed in that space of 30. And the issue there is these tissue level implants, they come in pretty big platforms. They're rather large. So when you have a tight space and you go ahead and place a big implant, what does it do is it remodels the tissue on natural teeth. What happens when you remodel tissue on natural teeth? The bone gets remodeled too. And so then you start to see that you see recession on the natural teeth pulling away. And so for me, again, as an implant itself, like if a surgeon were to come to me and be like, do you like tissue level implants? I'd be like, yeah, I love tissue level implants for all the reasons that you said. But case
Yeah.
selection is also really, really
I
important.
mean, you're alluding to aesthetics of it too. I mean, like you
100%.
can't control that as much on it. It's what I'm saying. Once you recede past the exposure of that portion, you're done. You know, you're done,
Exactly.
and it happens a lot.
And
That's
then
why I don't mind it
also
as much in the posterior as the anterior. But
100%. And they also have, like, I think they got a bad rap because of how they used to be restored, which was with the solid abutment, which was essentially like a crown prep that you screwed into the implant and it didn't have a screw. And those were problematic 100%. And from there, you saw this whole like exodus, like, oh, we don't do tissue level. And now we're like coming back to tissue level. And so, as a connection, as a whole, as an implant, no issues. But yes, like you said, aesthetics and placement have to be like spot on.
And that's why I don't think, again, it's for me at least, the implant because again, I don't want 20 implants in my closet. So the bone level implant just makes the most sense because it's versatile. I can use it in both scenarios. I can use those implants to put multi-unit abutments on them, to do full arch fixed cases instead of things like that. So the which brings me to my multi-unit abutments also, which is in essence kind of like a tissue level um attachment. That's the whole point of it, and correct angulation and things like that. And it does make it then on the surface of the multi-unit abutment, an anti-rotational device. I mean, sorry, a free rotational surface. So that's why you need more than one, um, ideally more than two. Have you done a 2-unit bridge on multi-unit abutments?
It's not my favorite to do. This was, I guess, yeah, it was 2 units. It was on a post resection case. So, tumor in the anterior mandible was resected, reconstructed, and we just got implants in where we could because these are really hard cases and the angles were obviously really challenging. So we, used multi-unit abutments. And by the way, doing this is not anything novel. Maxillofacial prosthodontists have been doing it routinely. They are probably the ones that do this multi-unit on a bridge concept the most because they're dealing with resection cases. So high tissue columns, weird angles. It's great in the sense that you can have a lot of control, a lot of correction. You can correct 17 degrees, 30 degrees, and you're bringing it away from the head of the implant, right? The idea is you're taking those possible complications and bringing them up so that if those complications arise, it's easier to manage. The challenge here is the incidence of complications, right? You're now asking for a prosthesis to be held, a 3 or 4 unit prosthesis to be held with these tiny, tiny little prosthetic screws. And, in the anterior mandible, like my case, not a huge deal. Like, hey, patient, don't bite into apples, carrots, or celery. You should be okay. But posteriorly, I don't think there's enough data out there to make me feel comfortable enough to do it.
I have a handful on 2 in the front. I've got anything that's gone posterior is 3 at a minimum. So 3, I've done it. I've done it at 3. 3 I've done, but yeah, in the interior, nothing's going more than 2, and that's just my comfort level. I've thought about it a couple of times. I was like, like a family member. I was like, let me try this. Someone who would let me, like, I know I can fix it if it breaks. But no, I haven't done that one yet. But yeah, again, from an implant abutment standpoint, it kind of shifts all the stress up, which takes sometimes a little bit of the potential biologic complications away if everything is still fitting, even at that multi-unit abutment level, which I feel like back in the day was a big issue on hybrids and on multi-unit abutments, is that the process of getting a verified cast was cumbersome, and let alone implant dentistry is confusing enough. So a lot of dentists just skipped the verification process, and that's the only conclusion I can come up with at watching all these misfits. And as soon as it stops fitting right, one gets loose, it starts to rock, and then maybe one multi-unit abutment is actually attached to the whole prosthesis, to a whole arch, and that one multi-unit goes down and starts flex. It causes a chain reaction when one doesn't sit. Yeah.
Well, I mean, it goes into the concept of passivity, right? Like, I remember when I was in my residency, we would have our impression copings, we would string floss, we would lute the pattern resin, we'd cut the pattern resin, we'd relute it together. Yeah, it was horrible. It was horrible. And I still remember being so like frustrated by the process. And like, even then, that laborious process I just described to you was unpredictable. Like, you would do all of this work and you still might not
You
have the
verify your
passive master
verification
test.
jigs.
Yeah,
I
yeah,
was like,
yeah.
please be ready.
And
Yeah.
and I remember like one time telling my faculty, I'm like, "Oh, who cares this much?" And he was like, well, you should.
Yeah, yeah,
And
yeah,
it's
yeah.
because now in my office, I see so many issues. And the one thing that it relates back to is lack of passive fit. Like,
Mhm.
there was not passivity. And exactly what you said, we're harping on micro gap, for inflammation. Okay, what about a macro gap where every time they bite down, it's doing like this? Like,
Right.
what's going to
Right.
happen then, you know? So yeah, I think the number one key to success, especially with multi-unit abutments where you're bringing everything up, has to be passive. Has to be passive.
So I right now I feel like I've been focusing in. I've been bringing you onto the bone level side of things. Now I
Yep.
want to get to the actual abutments. Obviously, like I most of the time I'm going with custom abutment most of the time. Mainly because I'm restoring at the abutment level, so I stop there most of the time. And my general rule of thumb is in the posterior you're probably getting some form of custom abutment. And even if it's a screw retained crown, you're getting a custom base. Um, on that implant. So it's still custom. It's not a tie base. The only time really I'm deploying the tie base is typically in an angled screw access channel that's happening in the anterior for me. That's just my most common usage. And also for aesthetic cases where I feel like the abutment is going to bleed too much through. I don't like to go like full zirconia into an implant.
No,
So
no.
I've done. She's like, don't do that. I
No, don't
actually
do
had. I had a
that.
dentist. Again, these are all. The only reason I bring these up is these dentists. These are reasons dentists have left me. Let me tell you my breakup stories here. I had a dentist
You should have a
stop
whole
referring to
podcast
me.
on
Yeah,
that.
about breakups. Yeah, yeah. Oh, because I'm getting more. I don't know. I just feel like I'm getting to a different point in my career, and I'm just not the guy that does the donuts. Like I'm
Yeah.
not. I'm not. I was at my last like event, and I was like, guys, I'm sorry. I never do that. Um, I probably never will. So if that's what you want, we might as well just end it here. You know, we're not. I'm never gonna be
Yeah.
that guy. And I when I the oh yeah, the zirconia case. So the doctor it was a number 31. Number 31. She wanted me to put a zirconia abutment because she's an aesthetic doctor and she only does zirconia abutments. And I'm like, okay, this is what we're gonna do. I'm gonna tell her that. So I talked to the patient. I'm like, hey, do you care? He's like, no, it's in the back. I don't want it to break. So I told the patient and put a metal I put in an Atlantis abutment, titanium. I gold shaded it. I anodized it at least. Beautiful,
Amazing. Amazing.
beautiful. She called me. She's like, this is not what I asked for. She's like, and I was like, you know what? Talk to your patient about it. You know, the patient's
Yeah.
yeah.
No, we're not putting zirconia into our implants,
No,
guys.
yeah,
We're
stop.
not doing that. Don't do
Don't do it. Put a tie
that.
base, and if you want a zirconia abutment, then the zirconia goes onto the tie base,
If
right?
you want it that bad, go ahead and do it, but you'll come back around and just do a custom
Just a
abutment
custom
anyways.
abutment.
So
But no, I've had it. I feel like I've had issues where it's like I still see the gray shine through, and those are the times. But again, most of the time now, if it is in the anterior, a lot of times it is like an angled screw access channel for me.
yeah,
And
same.
again, man, it would be great to have your card in a moment with an angled screw access channel.
This is why I started doing them. I had a
Yeah,
case that was referred to me and it was stripped screws on an ASC, an angled screw access or angled screw channel. And I was like, this sucks. This
yeah,
sucks for me,
yeah.
for you, for
Right.
everyone here.
You
This
don't
sucks.
know. How do you know? There's no
And
really no
yeah,
way to know.
that's really where that started. Yeah, like I say this, I'm a custom abutment clinician through and through. Like it's my happy place. It's predictable.
It's
Yes,
the
it's more
patient's happy
expensive.
place. Oh my god, the
Yeah,
chances that they don't feel like they're getting their tissue squished because
exactly. And you know what? Yeah, it's more expensive. Like I'm the first to say that. We run practices, we have to talk about the business side. There is a cost to it, but long term, you have just fewer complications, fewer biological issues, fewer issues with maintenance, redos, whatever it is. And
redos. You just hit. So
yeah,
I've traveled through an office that wanted to use only tie bases, and because they were milling everything in house, so they wanted tie bases and everything. And their appointments, their reappointments, because they were having issues seating an implant, was almost every other patient couldn't get done in an hour because with their implants, and they would actually I would get referral like patients that I would place the implants. It was an office that I would travel to. They would then set up an appointment with me, and I wouldn't be there that often. I'd come like once a month to contour more bone so that their tie bases could fit. And I'm like, wow, we just wasted. an extra appointment. You wasted my chair time there that I'm valuable to you to do my surgeries. Like you're wasting the time that I could be doing because they're not using some kind of custom abutment with a good emergence profile.
Emergence profile.
So
And look,
and
our companies
I could
are,
see them in like 5 minutes. You know,
yeah,
my restorative appointments are short and easy when I use a custom abutment. You
yeah.
save money. I
And
do think ultimately you save money.
I do. I believe that 100%. You do ultimately save money. And look, on the tie-based side, our industry partners are catching on, right? They're coming out with variable heights, they're coming out with variable sizes, they're coming out with different retention and resistance tolerances. All of that is well and good. And again, for a majority of the population, if you're screening them correctly, it might be okay. I am not seeing that version of the population in my practice. But I still believe that if you want to be an implant dentist, you should be familiar with how to generate a custom abutment, or what does it mean to generate a custom abutment? How do you script for it? How do you design it? What is the emergence profile? What is it going to look like when you seat it or restore on it? I think that's really valuable information. And look, the knowledge is already there. It's the most ideal crown prep in an abutment. Like that's what an abutment is, a custom abutment, right? So yeah, I do custom abutments. I do a lot of angled screw access channel, and we are now starting on the market to see custom angled abutments. Those have been, I've done a few recently, just fabulous, like fantastic. They are often generated by third parties, not by the manufacturer itself. But some of our manufacturers are catching on. And I had one that I restored it was 8 through 10 bridge with custom angled abutments. And I mean, when I looked at that radiograph, I was like, this deserves to be in a textbook. Like it was just so perfect.
And you know what? I don't think you could put a price on the beauty of looking at it and being like, ah, I created a good, like I did everything I could, you know, like
Actually, what the ultimate compliment was for some reason, this patient, she ended up needing to see an oral surgeon for something lateral to that site. I think it was like a fenestration or something, not on the prosthesis that we had done. And so the surgeon had requested that I remove it just for better access. And I was like, yeah, not a problem. Removed it, and I was like, yeah, I don't like, we work in the same building. I was like, I don't mind coming up and I'll put it back on if you want. He's like, oh, I got it. And so he replaces it, takes the radiograph, and then I come back up there just to like check and to get my driver back. And he was like, this is beautiful. And I was like, I know. The patient was like, you guys are such nerds.
that's awesome. The I was just thinking of something too. When these abutments are being seated, and there's an issue with the seating, and let's say you're actually able to sense that there's an issue with the seating. What do you find is like the most common issue you have seating an abutment? I mean, you probably don't have many if you're using custom abutments. I will tell you that if you're having a lot of issues, figure out what kind of abutment you're using, and I'll tell you if you're. And the lab that I work with, I've worked with a few labs. There's one lab that their custom abutment fee is very analogous. They make their own custom abutments. Their custom abutment fee is it's close to using a tie base. Like they don't charge much different there between the two.
I would say first, like you have to know what you're getting, right? Like again, don't send it and say, make me a tooth. Like understand what you are getting back. And a lot of labs, to the lab's credit, I look at these lab scripts and they have it listed. They have like these options listed out. But again, if you're in a busy practice or if the assistant's writing the lab RX and they send it off, you might not know. So 100% know what you're getting, and also know the screw. The screw makes the difference. So the lab, they might send you 2 screws. You don't need 2 screws. The 2 screws have different purposes. One is a lab screw and one is a clinical screw. So make sure you're using the right screw. That's number one. Number two, make sure you know what kind of abutment it is. Number three, if you are having an issue and it is not seating all of the way, take a radiograph. If it's the bone, if you truly feel like you can't get this seated because of the bone interference, it is most likely a tie base that this was restored on. And you have two options at that point: send them back to surgery, get the bone recontoured, or turn it into a custom abutment. I'm going to tell you your better option is to do a custom abutment, because telling that patient to go back to surgery is like, that's not going to go over well. And then the other issue I see with abutments is a lot of the times clinicians will try to seat the abutment and screw the screw at the same time. Like, I don't
Oh,
know if that makes
yes.
sense.
Yes. Yeah, I
Like,
used to do that. And I used to be
yeah,
like, what the heck is, and then I
yeah.
like, oh yeah.
Yeah,
Yes.
don't do
Yeah.
that. Seat the crown, put it in, and then take the screw with the screwdriver and then try to screw it in. Again, we spent the better part of the beginning of this conversation talking about internal interlocking of the implant. The implant should have its own anti-rotational indexing. In theory, again, we have gravitational forces if we're working on the maxilla, we have tissue as well, but in theory, you should be able to put an implant crown into an implant and let go. There should not have to be a screw, right? But make sure that I would always recommend seating the implant crown first, check the contacts, make sure that it's not too tight, then bring that screw in and start tightening it down.
Yeah, because I basically what they're saying is if you're sticking the screw in first, sometimes the screw is hitting the internal of the implant before the abutment is, and you can't get it in because it's just literally whacking around into like it's poking out the bottom of the abutment, and it's gonna stop you.
It's going to stop you. Yeah. Or you're going to start like engaging it into the implant in a weird way, and then it's not going to go all the way down.
Because you can keep tightening that screw to a certain point, and the screw will start threading, but the abutment hasn't gone in all the way yet. Yeah. The uh 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 I've like there are scenarios though, like if especially if it like in certain anterior regions where there's maybe a bigger tissue column, or there hasn't been enough contour of the soft tissue where it is harder to do that. So again, and there like behooves you to either use wider healing abutments when you can, or push the tissue in some format so that if you have trained the tissue, it is easier to just seat the crown and abutment together and without the screw.
Yeah. My last thing there I was just going to say is don't go fast. So a lot of the times it's like boom, boom, tight, tight, tight. Okay, done, walk away. Tissue is powerful. I mean, I don't have to tell a periodontist this because you're like, this is my world, but like tissue is very powerful. It will loosen the screw. It will push on your abutment. So don't go fast. Like spend the time. This is why we try not to anesthetize when we deliver implant restorations, because if they're feeling the pressure, if you're seeing the blanching, slow down. Just take it easy. Go step by step, because the worst thing you can do is like slam it in there, torque it down. They're back in your chair 24 hours later. Like, I think it's loose, you know?
That and if it's that, like there's like I'm looking for a certain level of discomfort. Like my hopes is none, which happens sometimes. If you're not training the tissue, you're going to be fighting more often, creating that connection. If you train the tissue and you use a custom abutment, minimal to none. Hear me out. If that's a problem you're having, focus on training the tissue more, whether that's custom abutments, wider healing abutments, and use a custom abutment, and you will solve that problem significantly. Um, the other thing is, in those scenarios where I do feel like I've got lots of thickness of tissue, and I am going in mostly, there has been times though I've been able to like use the screw to start, and then I'll start pressing to like feel it drop in just a little bit. I'm like, okay, now I'm in. Now I'll continue with the screw. But in those scenarios, I do exactly what you're saying. I don't just twist all the way. I twist, 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 look, twist, 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 look. And if it's in those scenarios, you're probably going to be pinching the patient to a certain extent. So prep him. Everyone gets prepped. Hey, as I'm putting this in, you might feel a little pinch. It's quick. It's faster than me numbing you, even though sometimes it might be better if they would have been more comfortable. But I need to know how much it's pinching. I need it to go away pretty much right away.
That's exactly what I say. And then
Yeah,
if they don't feel anything, you're like a hero. They're like,
yeah.
oh my gosh,
So,
you're so gentle. I'm like, I know.
and you feel great. You're like, "Jeez, thank
I'm like,
God."
yes, I am
Yeah,
amazing.
right. Because the whole process sometimes
Uh,
they can be numb for almost everything you do to that point. And so
yep.
when that's the final point where they're like, God damn it, I liked you till now. And then
Yeah.
no, screw you. I'm going to another doctor.
I always joke like because I do a lot of like collab cases where it's like perio pros or surgery pros, and I always joke I'm like, and especially if it's implant dentistry, I'm like, well, you're gonna love me because I don't have to anesthetize you.
Yeah, yeah,
Like
yeah,
I'm
yeah,
not the
yeah.
bad guy,
You're not
and they're like,
focused.
especially our full arch cases, like I really don't ever,
Oh
I
yeah,
mean,
because it's at
have
the
to
multi-unit
anesthetize
abutment
them.
level. It's all at the top.
Exactly.
Yeah,
So I'm just like, I'm gonna be your favorite, and they're like, okay.
yeah, no, yeah. Well,
Oh man.
unless you pinch
Yeah.
him with the custom
Unless I pinch
abutment, and
him.
then you're
Yeah,
like, oh man,
exactly.
you're worse than the other guy. You at least numbed me
Yeah,
to do this stuff.
right.
Um, but
Oh.
I have seen scenarios where the pressure is too much, and you can. I mean, you can push it all the way down and squish it to the point where you can necrose bone. I've seen it. If the bone is dense, especially on lower mandibles with like tori, people who have really thick cortical bone and thin soft tissue, if they compress that much, I've seen chunks of necrotic bone come off, but the abutment is still in there. But then I've seen it happen where the bone necroses, then the abutment loosens, and then I'm sitting there. I remember at the times I was like, maybe it was the inflammation that caused the piece of bone to move, but then it would click. It's like, no, this was the pressure from the abutment that likely did it. And so that's why you don't want to over pressurize, and again, don't want to deal with that problem. Train the tissue, do a custom abutment.
Just take your time. Exactly.
So I'm going to summarize this. So the ideal scenario is conical connection with ideally own manufacturer custom abutment, sealed in there, torqued to whatever they recommend you torque it to with their right screw, not the lab screw. uh, and also, do you ever do a secondary, like once you torque it? Let's say I'm torquing like an Atlantis abutment on an Astra to like 25, and I stop. Do you ever like go back like 5-10 minutes later to like check and like do it again?
Sasha, always,
Oh
whoever is listening here, if you ever see me in real life, come up to me and be like, what do you think about the settling effect, which is
yeah,
what this is called. I
yes,
am
yeah,
very passionate about this. Like,
gotcha. Yeah, yeah, I triggered
I,
something.
oh my gosh, I literally have it on every lecture side. I am like, if you are not doing this, you have to do it. When essentially what Sasha was describing is seat your crown, torque it to, 25, 35 Newton centimeters, go to your office, drink a cup of coffee or go do a hygiene check or just wait 5 to 10 minutes because the literature shows us that 2 to 10% of the preload, which is that interlocking of the screw, can be lost within the first few minutes after torquing. And you might think like, okay, Varisha's sitting here and harping about like 10%. 10% will move the needle on your heavy bruxer, second molar, first molar
I'm
implants.
thinking of the one
So,
patient I have right now that I know
so
that happened to.
just wait, go back in there, put the driver in, put the torque wrench in, tighten it one more time. You're
So
good.
I will, yeah, once I seat it, I torque it. I actually like I've gotten so comfortable at like feeling that it's seated all, like if I know if like it's dropped in and it's seated, I'll torque, adjust the occlusion, then take a PA and just to waste time and then do it again. It started off for me just more like a almost like an OCD thing where I was like, did it go to, let me check again. Let me just check. That's how it started off for me. So I'd always do it. It was like an OCD thing for me. But now like and once I learned about the settling effect, I'm like, oh, I'm so glad I did that habitually.
You're like, oh,
Like
I actually came up with
I design, yeah, exactly.
that.
Duh.
But yes, do
Duh.
all of the things and your implant restorations will be beautiful and
Yes. And
easy.
you will have a happy implant abutment connection. Dr. Parikh,
Exactly.
thank you so much for getting unfiltered, guys. Again, she obviously has courses on the implant abutment connection. I think I actually did a webinar way back when as well. There's not that many good resources on the implant abutment connection, I'll be honest. So this might be one of your better ones, or a book, or our courses. Again, like, follow, comment, all the digital things you can do to support us. It really helps because we do not get paid. And I think Dr. Parikh's like, why the hell am I still doing this? Even though he's not paying me. And she gets paid. For the record, we do get typically paid to do these things.
Yeah. It's because we are so passionate.
And it cancels out because we both normally get paid and we're both not getting paid. We're both cool with this. And you guys are all welcome.
Thank you, Sasha, for having me.
Thank you so much. Till next time.
All right.